everyone. Good morning to fellow students of surgery. I was tasked to give this review on surgical critical care and trauma. So our learning objective for today is to know the salient points in surgical critical care, nutrition, and trauma. So trauma or injury is defined as a cellular disruption caused by environmental energy that is beyond the body's resilience. So it's compounded by cell death due to ischemia and reperfusion, and is the most common cause of death for all individuals ages 1 to 44. It is the third most common cause of death, regardless of age, and it has a bimodal distribution with regard to mortality, around 16 to 40 years of age and more than 65 years old. So we have to um, understand the immune response to trauma. So once you have injury, trauma will lead to damage of your external and internal barriers, and will expose the patient to damage associated molecular patterns, or your pathogen associated molecular patterns, your dumps or pumps. So this would trigger a cascade, a danger signaling, and then of course it will produce and translate and signal other pathways, including your immunological coagulopathic pathways. And of course, if there is no balance in the immunological control, then this would lead to your organ dysfunction and multiple organ dysfunction syndrome. So it is important that there should be a balance between your pro-inflammatory and anti-inflammatory mediators. So some of your pro-inflammatory mediators includes your tumor necrosis factor, your interleukins 1, 2, 6, and 8, interferon as
Dr.
well.
Garito Alexandra.
So it's very important the student should
Dr.
be able
Garito
to
Alexandra.
understand these pathways when talking about uh, trauma. Okay, and to elucidate more, so once you have injury to your tissues, there is a activation of several pathways, your autonomic nervous system, your coagulation pathways, the complement systems, and their cellular defenses. And of course, this will induce microcirculatory disturbances, and if not checked and when and goes in unbalance, then it will go and produce your organ dysfunction and organ failure. So let's go to the initial evaluation and resuscitation of the injured patient. So basically, it has several parts: your primary survey and concurrent resuscitation, secondary survey, definitive care, and tertiary survey. So of course, we have your ABCDEs when we talk about your primary survey with concurrent management. Your cervical spine stabilization is contained within your area assessment and protection. Okay, you have your breathing, ventilation assessment, your circulation, disability, and exposure. So almost invariably, your patient will present with some form of shock. Okay, so in patients with trauma, so it can be roughly divided to hemorrhagic and non-hemorrhagic, and you have this your non-hemorrhagic causes as well. So this table shows your classes of hemorrhagic shock, okay, and the signs and symptoms. So basically, your heart rate will start to go up during class 2, okay, which is a 15 to 30% of approximate blood loss, and your blood pressure will start to go down around class 3, and then of course you'll have your change in sensorium, okay, and change in GCS once you approach class 3 as well. Okay, the worse as your base deficit worsens, of course, then most likely that the outcome will be not good. And if your patient presents with a higher class of hemorrhage, of course, then you might need transfusion of your blood products. Okay, this diagram shows you the relationship of the base deficit with mortality in trauma patients. So like what I said in the previous slide, as your base deficit worsens, of course, mortality worsens as well if this is not managed or there's no intervention done. So this is a flow chart uh, when we classify shock, okay, uh, in patients who present with shock in the trauma bay. Of course, you classify these patients into three, okay, after fluid resuscitation, if they are non-responder, a transient responder, or responder. And then, of course, it depends if they are non-responder and transient responder, they may need some form of intervention, laparotomy or angiography. And then if patients are responder, then you'll have to rapidly evaluate the shock state. Okay, is it a hemorrhagic? Is it other causes like a neurogenic shock or a septic? And have to manage it appropriately. Okay, your secondary survey, your AMPO, okay, will include your allergies, medications, past illnesses, last meal, and events. So basically a head-to-toe exam, and adjunctive tests can be done during this time. Okay, FAST. FAST is, as you know, the naming is focus assessment with sonography for trauma. It is an essential part of the primary survey circulation for unstable patients, and it detects pericardial and peritoneal blood. It is more accurate than physical exam findings in detecting intra-abdominal injury. And in hemodynamically stable patients, FAST can be delayed until the secondary survey. So these are your common areas where we scan for your FAST. Okay, so your pericardial sac, your splenorenal hepatorenal areas, and then the pelvic area. Okay, EFAST or extended FAST, okay, is basically you add another view, okay, another examination to your FAST. Okay, this one checks your chest, okay, so you have to check for signs of pneumothorax. So normally, if once you scan the chest area, you should be able to see this seizure sign or the sliding pleura. Okay, if you cannot visualize this on your EFAST, then probably your patient has pneumothorax. DPL or diagnostic peritoneal lavage. It has a role similar to FAST in the unstable patient, and it can be performed to detect intraperitoneal blood when FAST is unavailable. It is highly sensitive, but the disadvantages is, of course, it is invasive and it can actually potentially injure the organ. Positive findings will include 10 ml of blood. There's feces, bile, urine, food particles, and once there is no once during the initial aspiration, if you don't see blood, okay, if you don't aspirate blood, then you have to instill saline, and then drain it into a bag. Okay, so and send it to the laboratory. The microscopically, it should be an RBC count of more than 100,000 and WBC of 500, more than 500. Let's go to head injury. So some principles: all patients with a significant closed head injury, GS less than 14, should undergo a cranial CT. Elderly patients or those on antiplatelets or anticoagulants should be imaged despite the GCS of 15. For penetrating injuries, plain skull films may be helpful to determine the trajectory of a projectile. So these are your this is your GCS scoring. Okay, so basically when you do the GCS, you have to get the best scores that you can do, best response of the patient. So epidural hematoma, it's blood accumulates between the skull and the dura. It is due to the disruption of middle meningeal artery, and it basically shows as a convex or lenticular shape on CT. While subdural hematoma, it occurs between the dura and the cortex, and it is caused by venous disruption or laceration of the parenchyma. and generally have a worse prognosis than epidural collections. And on CT, it will show us a crescent-shaped hematoma. And next one is a diffuse axonal injury. Okay, it results from high-speed deceleration injury and direct axonal damage from the shear effect. Okay, CT findings will include a blurring of the gray and white matter interface and multiple small pancreas tumors. Basically, patients will have poor outcome. Okay, for depressed skull fractures, relative indications will include the depression of greater than 8 to 10 millimeters or greater than the thickness of the adjacent skull. Focal neurologic deficit, okay, significant inward intrusion of the bony fragments, and persistent cosmetic deformity after the swelling has subsided. So in head injury, basically you have to, ideally you have to have ICP monitoring, okay? Especially on patients with abnormal OP findings of GCS of less than an 8, and you have to target an ICP of less than 20 millimeters mercury. Some institutions can monitor the CPP or the cerebral perfusion pressure. You have to keep it more than 60. Okay, you have to remember that CPP is equals to MAP minus an ICP. Indications to remove a space-occupying hematoma are based on clot volume, amount of midline shift, location, GCS, and ICP. So this is an algorithm in managing TBI. Okay, so I want you to focus on this square over here. Steps to control elevated ICP. So elevate the head. Okay. You can give sedation and analgesics. Okay, you can give your osmolar therapy as your like your mannitol and hypertonic saline. Okay, you can if the patient is ventilated, you can mechanically ventilated. You can induce hyperventilation. Okay, of course, minimal hyperventilation. You have to keep the PaCO2 around 30 to 34 millimeters mercury. Okay, below that, it will not be. It will be detrimental to the patient already. Okay, you can use paralytics, and you can use a hypothermia or an induced coma or decompressive craniectomy if other measures doesn't affect. Okay, for maxillofacial trauma, okay, you have your Lefort fractures. Lefort 1 is a transverse fracture through the maxilla above the roots of the teeth. It can be bilateral or unilateral. Your Lefort 2, it's typically bilateral. Fractures that extend superiorly in the midface include the nasal bridge, maxilla, lacrimal bones, orbital floor, and pin. And your Lefort 3 will be your craniofacial dysfunction or dissociation. And the fracture is basically produces discontinuity between the skull and the face. For neck trauma, some principles would be such as blunt trauma patients should be assumed to have C-spine injuries until proven otherwise. Hard C-collar or sandbags on both sides of the head. Cervical collars are not recommended in penetrating neck wounds. Okay, it has no benefit and may interfere with assessment and treatment. The incidence of cervical spine fracture and cervical spinal cord injury from gunshot wound and spinal and stab wounds are basically low. Okay, these are your landmarks for your zones in your neck. Okay, zone 1 is from your sternum anterior cricoid cartilage. Zone 2, cricoid cartilage until your the angle of the mandible, and then the zone 3 is above that until the base of the skull. Okay. Okay, these are the important structures contained within each zone. Okay, so your arteries are much of your blood vessels are contained in the zone 2 as well, and your vertebral artery is contained is in your zone 3. This table lists your hard and soft signs. Okay, hard signs for vascular injury, severe uncontrolled hemorrhage, large expanding pulsatile hematoma, Lewis and Fields, of course, shock unresponsive to IV resuscitation. And you'll also have your hard signs of aerodigestive injury, air bubbling, massive hemoptysis, respiratory distress. Your soft signs would include minor hemorrhage, minor hemoptysis, subcutaneous emphysema, dysphonia, dysphagia. This algorithm shows on how to manage penetrating neck injuries. Okay, if you have hard signs and the patient is unstable, of course, you have to bring this patient to the operating room. Okay, if the patient is stable, has no hard and soft signs, of course, just have to do serial examinations, or you can do imaging studies depending on the institution. And yeah, okay. Okay, this figure shows the standard neck incision when you do a neck exploration for neck trauma. Okay, basically it's the standard neck incisions anterior to the sternocleidomastoid muscle. Okay, you can extend it, okay, to the sternum as an sternotomy. Of course, you have your collar incision and extensions for your supraclavicular book thoracotomy. Okay, let's skip this. Okay, so for blunt chest trauma, rib fractures are identified in nearly 2/3 of motor vehicle collision patients. Sternal fractures are found in 8%, and scapular fractures are up to 3.7%. So chest wall injuries that are associated with increased risk of significant intrathoracic or intra-abdominal injury would include scapular fracture, flail chest, multiple rib fractures, sternal fracture, and posterior sternoclavicular dislocation. Basically, this the forces applied when you have this kind of injuries are very large. That's why you have to you will deduce that there is a concomitant associated or associated risk of significant intrathoracic injuries. So failed chest is defined as fractures of 3 or more adjacent ribs in 2 or more places. It occurs in 5 to 13% of patients with chest wall trauma, and the underlying pulmonary condition includes shunt and consequent hypoxia. And then pneumonia and respiratory failure are common complications. So management will include pain control, adequate oxygenation and ventilation, judicial fluid resuscitation. You can place a CPT. Of course, you give DVT prophylaxis for the critically ill, and antibiotics if you have a CPT. How about operative fixation? There is no role for surgical stabilization for patients with severe pulmonary contusion as a cause of respiratory insufficiency in flail chest. So let's go to penetrating chest trauma. So any penetrating injury to the chest must be assumed to have caused internal organ damage, which may involve the following: heart, blood vessels, lungs, tracheobronchial tree, spinal cord, esophagus, and the diaphragm. Hemothorax and pneumothorax are the most common sequelae from both penetrating and blunt thoracic trauma. More than 85% can be definitively treated with a chest tube, and if unstable and in distress, you have to consider the big three: your tension pneumothorax, a massive hemothorax, or cardiac tamponade. For tension pneumothorax, findings would include absent breath sound on the affected side, pressure shift, aside from your unstable hemodynamics. So management for this will be needle thoracostomy as a temporizing measure, and afterwards you can insert your chest tube. For cardiac tamponade, consider if you have entry wounds within the cardiac box, distended neck veins, and heart sounds. So definite management, of course, a median sternotomy. But for patients in the emergency room who are unstable in extremis, you can do an emergency pericardiocentesis with a cuff replacement. So this is temporary, of course, just a temporizing measure until you do your definitive management. So for massive hemothorax, you have to insert large bore chest tube for this. Indications for thoracotomy will include the initial drain of more than 1 liter or an output of more than 200 cc per hour for 2 to 3 hours, or if there's hypotension despite a CPT and volume resuscitation. Okay, I included slides for ED thoracotomy, and I've written some recommendations from different trauma societies, okay, and organizations. So basically, ED thoracotomy is a debatable topic in the community, but I'll just mention this in the ACS Commission on Trauma recommendations. They say that it is best applied to patients sustaining penetrating cardiac injuries who arrive at the trauma center after a short scene and transport time, and with witnessed or objective measurement of physiologic parameters showing signs of life. And it should not be performed in patients sustaining cardiopulmonary arrest secondary to blunt trauma because of its very low survival rate and poor neurologic outcomes. In the EAST guidelines, okay, the Eastern Association for the Surgery of Trauma, so they recommended that patients who present pulseless with signs of life after penetrating thoracic injury, okay, strong recommendation, and a conditional recommendation for patients who present pulseless and have absent signs of life after penetrating thoracic injury, or present or absent signs of life after penetrating extrathoracic injury, okay, or present signs of life after blood, okay. So for this, the other one is the Western Trauma Association guidelines. They said that it is indicated for blunt trauma patients less than 10 minutes of pre-hospital CPR, or for penetrating torso trauma patients with less than 15 minutes of CPR, and patients in profound refractory shock or penetrating trauma to the neck or extremity with less than 5 minutes of pre-hospital CPR. Let's go to the liver. So the liver is the most frequently injured abdominal organ. Most hepatic injuries are relatively minor and heal spontaneously with non-operative management. Operative intervention to manage the liver injury is needed in approximately 14% of patients, and it is the most commonly injured organ in blunt abdominal trauma and the second most commonly injured organ in penetrating abdominal trauma. Okay, all data will say that most hepatic injuries are low grade. In the NTDB study in 2008, 67 were grade 1, 2, or 3. And the AST grading is useful for predicting the likelihood of success with non-operative management. So higher for low-grade injuries, of course, and for high grade, like 4 or 5, lower. So this table shows you the AST grade for liver trauma, severity, AIS severity, and then criteria for CT findings, operative, and pathologic. Okay, so patients with blunt liver injury who are hemodynamically stable and who do not have other indications for abdominal exploration can be observed. Okay, stable patients with right-sided penetrating thoracoabdominal injuries that lacerate the liver can also be observed, provided there are no associated intra-abdominal injuries. Non-operative management is a treatment of choice for stable patients with hepatic injury, regardless of injury grade, and consists of observation and supportive care with the use of angiography and hepatic embolization. So of course, there are contraindications for your non-operative management. Okay, patient is unstable after initial resuscitation. Other indications for abdominal surgery, like signs of peritonitis, if it's a gunshot wound, okay, it's a relative contraindication, and absence of an appropriate clinical environment, such as an ICU. So if your institution doesn't have a unit where you can closely monitor these patients, then it is advisable not to do an non-operative management. Okay, criteria to terminate non-operative management once you have started it. If patient develops hypotension, okay, attributable to the injury, if there are signs of hollow viscous injury during your serial abdominal exam, and development of septic syndrome despite normal abdominal findings, and deterioration in vital signs. Okay, these are the following techniques for hemostasis. You can do manual compression. You can do you can apply pressure in the porta hepatis, your Pringle maneuver. Okay, can include your portal and arterial blood supply. Okay, you can do perihepatic packing, topical hemostatics, cautery, vessel ligations, of course, and then direct liver suture. Okay, so this figure shows how to properly pack a liver laceration. Complications will include hemophilia, which will present as upper GI bleeding with jaundice. You can also have biloma, persistent bile leak, perihepatic abscess, and hepatic necrosis. Spleen is mostly the injury for in the spleen is uh, mostly arise from blunt trauma, okay, motor vehicle collisions, fall, or sports injury. Iatrogenic trauma can result from surgical or endoscopic manipulation of the colon, stomach, or pancreas or kidney. It can be managed non-operatively with selective embolization, with or without selective embolization if the patient is stable, and with a low grade of injury, grades 1 to 3. So for unstable patients, you have to do an emergent exploration, and your possible complications will include subphrenic abscess, post-phrenic sepsis. Duodenal injuries are relatively infrequent. It accounts for approximately 3 to 5% of all traumatic abdominal injuries. The spectrum of injuries will include hematomas, perforations, and combined pancreatic or duodenal injuries. So for duodenal hematomas, most majority of them are managed non-operatively with an NGT and TPN, and the resolution of hematoma typically occurs within 2 weeks. Repeat imaging is optional, and if you have a clinical deterioration while imaging, or if there's a presence of pneumoperitoneum, then you have to do your expiratory laparoscopy. Okay, low-grade partial thickness injuries, grade 1, are repaired by suturing the serosa in a Lambert fashion. Full-thickness duodenal lacerations are debrided, and the duodenum is repaired with a tension-free primary closure in 1 or 2 layers. And longitudinal injury should be closed transversely if possible to minimize the potential for luminal narrowing. If the injury is judged to be too extensive for primary repair, for example, more than 3 cms after debridement, the injured segment should be resected, and the end should be brought together with the primary end-to-end duodenoscopy. Injuries to the second portion of the duodenum may not be amenable to this approach if the common bile duct or ampulla is injured, or if resection would be required to remove all these structures. So for intermediate grade, grade 3 injuries, it can be treated with debridement, primary closure, resection, and primary anastomosis. When primary repair is not possible, surgical options include resection with pre-anastomosis duodenodurneostomy. For larger defects, you can do duodeno J with 2 and Y reconstruction, and of course, plus minus pyloric exclusion. For high grade, for limited injuries to the ampulla, management options include stenting or sphincteroplasty. Extensive periampullary injuries such as intraduodenal bile duct injury, intrahepatic bile duct injury, grade 5 injury, then it will require trauma repose. So most pancreatic injuries are low grade, and most can be managed non-operatively. When injury to the pancreas is identified during abdominal exploration, the integrity of the main pancreatic duct should be evaluated, and the location of the injury ascertained. So this is a useful algorithm that we can use for pancreatic duct injury. Okay, in proximal, okay, duct injury, you just have to we put a closed suction drain. Okay, for distal, okay, there are options for distal pancreatectomy. Okay. So let's go to colon rectal injuries. So management of non-destructive colon and intraperitoneal rectal injuries usually is just done by primary repair. Okay, outcomes are very good. And injuries not amenable to primary repair, you can do a resection and anastomosis. In most cases, you can, and of course, if you have a patient who has poor physiologic status or unstable hemodynamics, then you can do colostomy. for extraperitoneal rectal injury, you can do diverting colostomy alone. Some studies show that it is an adequate measure for this kind of injuries. Complications will include intra-abdominal abscess, around 10%, fistula formation, wound infection, and stomach complications. Injury to the retroperitoneum, okay, it often accompanies abdominal trauma. It contains organs that are entirely within the retroperitoneum, as well as some organs that traverse from and back into the abdominal cavity. Incidence from blunt trauma is around 44 to 80%. From penetrating, it's around 20 to 33%. In one review, 488 patients, 30% had an associated retroperitoneal hematoma, and most of them are in zone 2, okay, followed by zone 1 and zone 3. The most common injured organs are the colon, kidney, duodenum, pancreas, bladder, and rectum. So this figure shows the zones of the retroperitoneum and the major vasculature contained and the organs contained as well per zone. So when to explore a retroperitoneal hematoma, it depends on the mechanism of injury, zone, and organ injury severity. For penetrating injury, zone 1 should be explored. It is likely a major vascular injury. For zone 2, you can selectively explore the kidney for active hemorrhage or an expanding hematoma. You have to adequately mobilize the colon. Okay, you have to do your visceral rotations. You can do your Patil maneuver or your Mattox maneuver. Okay, in order to adequately expose the area or the zone that you want to explore. Okay, for zone 3, okay, you have to explore this. It's a likely major vascular injury. So this is for penetrating injury. For blunt injury, zone 1, explore. Okay, so it's likely a major vascular injury. For zone 2, if expanding, you have to explore. So if it's not, then do not explore a contained or non-expanding hematoma. Okay, so for zone 3, do not explore, regardless of the presence or absence of pelvic fracture. Okay, you'll use an alternative method for hemorrhage control, including pre-peritoneal packing, okay, or angioembolization. If you can do it intraoperatively with that. Okay, so for major pelvic trauma, pelvic fractures represent approximately 3% of skeletal injuries. Overall mortality is 5 to 16%. Unstable fractures will count around 8%. And the leading cause of death within 6 hours is hemorrhage. Okay, when you get pelvic fracture injury, you have to expect associated injuries as well in the genitourinary tract, okay, in the blood vessels, rectum, vagina, perineum, nerve injury. Okay, this picture shows how to place a pelvic binder. Okay, you have to position the sheet over the greater trochanters, and then the sheet should be overlapping, and clamps can be used to secure it properly. Okay, so another photo. Patient should be adequately exposed. Okay, coughing should be removed prior to application of your binders. Okay, this is what it calls a pelvic sling. Okay, they can use to buckle pelvis as well. Okay, so this algorithm shows the initial management of patients with major pelvic trauma. Okay, so if of course you have, if your patient is hemodynamically stable, then you can do your imaging studies. Okay, if the patient is stable, okay, and if the patient is unstable, fast examination is positive, then you have to bring the patient to the operating room. Okay, so other options you can use pre-peritoneal packing if the patient is in extremis. You can do Riboa as well, and of course you have to do your you have to apply the pelvic binders, and then if available, you can do angioembolization. The damage control surgery involves immediate control of bleeding sites and gastrointestinal contamination with delayed management of injuries. Intraperitoneal packing and temporary abdominal closure are followed by fluid resuscitation, warming, and correction of coagulation deficits in the intensive care unit. Okay, there are phases of your damage control. Okay, pre-hospital, initial operation, resuscitation, definitive repair, and of course, delayed soft tissue reconstruction. Okay, yeah, the goal is to achieve euvolemia, normalize tissue oxygen delivery, okay, resolve the acidosis, coagulopathy, and hypothermia, which is your default triad in severely injured patients, and providing appropriate airway and ventilatory management. The timing of definitive repair of injuries temporized during damage control surgery is determined by the patient's physiologic status, but typically it starts at around 24 to 48 hours after the initial injury. Okay, let's go to severe burns. A severe burn is one that is complicated by major trauma, inhalation injury, chemical burn, or a high voltage electrical injury, or any burn encompassing more than 20% of the TBSA, excluding superficial burns. Okay, okay, so we can assess the total body surface area using the rule of nine. So if available in your institution, you can have a lump powder chart. Okay, okay. Burn fluid resuscitation can be done with the Procter formula, which is 4 ml by weight in kilograms times the percent TBSA. Okay, you have to give one half in first 8 hours post injury and give the other half in the next 16 hours. Okay, other clinicians or other institutions will use the modified Brook. Okay, because they say that 4 ml is too much and will usually lead to over resuscitation and of course the concomitant side effects from over resuscitation. So they use 2 ml times weight in kilograms times TBSA, and same as the Parkland, you have to give one half in first 8 hours of post injury, give the other half in the next 16 hours. Okay, referral to burn center, a specialty burn center. Of course, if you have burns greater than 10% partial thickness, burns that involve the face, third-degree burns, electrical injuries, chemical burns, inhalational burns, inhalational injury, and burn injuries in patients with existing medical disorders, etc. So these are the indications for referral to burn center. Okay, so we're done with trauma. Let's go to some topics in critical care. Okay, let's start with sepsis and septic shock. So the new definition for sepsis since the 2016 is already changed when they released the sepsis 3 guidelines. So it's a life-threatening organ dysfunction due to dysregulated host response to infection, and septic shock, subset of sepsis with circulatory and cellular metabolic dysfunction associated with higher risk of mortality. So there's no more severe sepsis. Huh? So it's an old definition already. So you only have two: sepsis and septic shock. Okay, roughly it has four parts: resuscitation, investigating the cause, definitive therapy, and the adjustment measures. So you have for resuscitation, you have to give early effective fluid resuscitation. The surviving sepsis campaign, their recommendation is 30 cc per kilogram bolus initially, and you have to measure the hemodynamics with methods that are dynamic. Okay, pulse pressure variation, etc. And you have to maintain your mean arterial pressure at least 65 millimeters mercury at this level, so that in order to maintain adequate end organ tissue perfusion. Okay, you have to give crystalloids or balanced isotonic solutions. You can consider RBC transfusion for hemoglobin less than 7. And you have to use early vasopressors or inotropes if they don't respond to your fluids. So norepinephrine is the agent of choice. Your second line will be your vasopressin or epinephrine. Okay, dopamine is really not used anymore unless your patient is very young, has low risk of developing arrhythmias, or has relative bradycardia. Then you can use dopamine. Okay, when investigating the cause, you have to do blood cultures, urine cultures, okay, imaging studies, and you have to do source control as ideally around not more than 6 hours after the diagnosis. You have to use intervention that accomplishes the objective with the least physiologic onset, and intravascular devices that are a possible source should be removed promptly. Antibiotics should be started within the first hour after sepsis recognition. Should be broad spectrum, and you have to consider your local biogram, antibiogram, and take note of bioavailability, safety, and toxicity. Okay, for patients who develop adrenal insufficiency, okay, you can use corticosteroids. Okay, these patients usually present with hypotension, poorly responsive to fluids, and your vasopressors. So the drug of choice is hydrocortisone, 200 to 300 milligram per day, a day, as a 24-hour infusion or given on daily basis. You also have to do glucose control, avoid hyperglycemia and hypoglycemia. The target range is 140 to 80. And the recommended way to give insulin is via drip. You have also to give DVT prophylaxis for all critically ill patients, with either with unfractionated heparin or low molecular weight heparin. Nutrition, you have to initiate early enteral feeding when feasible, and early parenteral nutrition is not recommended for critically ill septic or septic shock patients for whom enteral feeding is not feasible. Prokinetic agents for feeding intolerance, glutamine, arginine, and selenium, not recommended for the septic patient. And personally, I use the Nutrix score in the ICU. Okay, so the Nutrix score is like this. So it checks your age, Apache 2, SOFA scores, number of comorbidities, and days from the hospital to ICU admission. So if there is no interleukin 6 available in the hospital, so a score of 5 to 9 is high risk, and 0 to 4 is low risk. So for high risk, you have to these patients will benefit most likely from aggressive nutrition therapy. Okay, so just a review. Your sepsis bundle will include these 5 things: measure your lactate, get your blood cultures, give fluids, antibiotics, and vasopressors within 1 hour. Okay, lactate clearance, of course, studies have shown that survival, okay, the probability of survival is better if lactate is cleared uh, as soon as possible in patients who present with hyperlactatemia. Okay, ICU scoring systems usually integrate easily measured data from patients into a statistical algorithm. Okay, it predicts patients' illness or how they progress or respond to intervention. In critical care, most relate to illness severity. Okay, so commonly used is the SOFA score and the Apache. So these are the variables checked with your SOFA score. Okay, your GCS, your PF ratio, okay, your coagulation, liver, your bilirubin, and then your kidney, which is your creatinine. You have to check your creatinine of your renal function. And based on the and also you have to your cardiovascular system, your blood pressure as well. If there's a hypertension, or use of vasopressors. So based on the scorings, then you have the higher the score is, of course, the mortality is higher. The Apache 2 score. Actually, there are a lot of iterations already of the Apache scoring. So the currently one uses the Apache 2 scores. The Apache 3 and Apache 4 have so many variables to check. Okay. Okay, the quick SOPA, the quick sepsis related organ failure assessment. So it basically checks three criteria, three variables in order to identify patients who are with greater risk of a poor outcome. Okay, so basically use this in the wards. Okay, where you check your GCS, your respiratory rate, and your blood pressure. Okay. 0 or 1 point, not high risk. If you have a score of 2 or 3, then high risk of poor outcome. So most probably this patient will benefit from aggressive monitoring and intervention. So I teach my residents in order not to forget how to manage patients with sepsis. You just have to memorize the mnemonics, okay? LMFAO, lactate, microbiology, food resuscitation, appropriate antibiotics, and of course your other interventions such as O2, source control, vasopressor. Okay, so let's go to hemodynamic monitoring. So I didn't list all of the list is not exhaustive, of course. So you have your invasive, like your pulmonary artery catheter or your Swan-Ganz catheter, okay, CVT, pulse pressure variation, and SSD, and then your in the transesophageal Doppler. Non-invasive, of course, will include your BP sphygmomanometer, point of care ultrasound, passive leg raise test, and bioimpedance tests, and sublingual microcirculation imaging, okay, NIRS as well. Then the simplest and most effective is your capillary refill count. Okay, for just maybe nice to know, okay, these are the values measured in Swan-Ganz catheter, okay, your wedge pressures, and your cardiac output and cardiac index. Okay, pulmonary disorders. Let's just go through it quickly. Okay. Okay, ARDS is a diffuse inflammatory injury of the lungs. And it is the inciting event is an activation of circulating neutrophils. Neutrophil degranulation damages the capillary, leading to production of protein-rich exudate that fills up the distal interstices. So the predisposing conditions will still be your pneumonia, sepsis, aspiration, and trauma. Okay, there are 4 variables in the Berlin criteria for ARDS: timing, imaging, origin of edema, and oxygenation. So for timing, should occur within 1 week. Imaging should show bilateral opacities consistent with alveolar consolidation, and there should be no evidence of left heart failure or fluid overload for the origin of edema. And your oxidation can be further divided mild, moderate, severe, depending on your PaO2 and FiO2 ratio. Management will include lung protective ventilation, judicious fluid use, prone ventilation, incremental PEEP or ECMO for those really with refractory hypoxemia. Okay, transfusion-related acute lung injury. It's an inflammatory lung injury caused by RBC and platelet transfusion. The incidence is 1 per 12,000 transfusions. Mortality rate is 6%. So TRALI is the leading cause of transfusion-related deaths. And inflammatory response results from anti-leukocyte antibodies, ALAs. Okay. Clinical features: signs of respiratory compromise, fever, diffuse infiltration in both lungs, and it will require ventilatory support. So findings usually an X-ray we like ARDS. So ongoing transfusion should be stopped. It is a mainly supportive care, similar to ARDS, and you can use wash RBCs if needed. So for hospital-acquired pneumonia, the definition is it occurs 48 hours or more after the admission and did not appear to be intubating at the time of the admission. So once HOP or VAP, VAP is a ventilator-associated pneumonia. Okay, yung definition naman ng VAP is 48 hours na naka-ventilator. So that's your VAP. So if it's suspected clinically, specimen should be obtained as soon as possible and antimicrobial therapy should be started as soon as possible. Okay, so risk factors for increased mortality for pneumonia or for hospital-acquired pneumonia. Of course, if patient is intubated and mechanically ventilated, or patient goes into septic shock. So these are the two risk factors for increased mortality. Okay, maybe we'll just skip this. Okay, let's talk about nutrition. I think we're about to finish. So fundamental goal of nutritional support is to provide your daily nutrient and energy needs of each patient. Can be given through the GI tract, enteral feeding, or intravenously, parenteral nutrition. So your basically your indirect calorimetry is the one used to measure your daily energy expenditure. Okay, using the whole body O2 consumption, VO2 and CO2. CO2 production. Okay, so it's not widely available in the country. Okay, not all institutions have this, so we just do the simple way, which is weight-based. Okay, we compute the REE, the estimated energy expenditure, to be 25 times the body weight in kilograms. We use 30 to 35 for hypercatabolic patients. So for obese patients, of course, you have to do calorie restriction. Okay, for protein, for the critically ill, it should be 1.2 to 2 grams per kilogram per day. Okay, carbohydrates usually 70%, lipids 30%. So if you have patient, of course, if you have patient who has acute respiratory failure, you have to bring down your carbohydrates. Okay?
Dr. Andrada, to Annex 5.
Okay, you have to give vitamins and minerals as well. Antioxidant vitamins may improve patient outcome, especially in burns, trauma, and critical illness. Okay. So basically you have to, as much as possible, you have to do enteral nutrition, to give enteral nutrition. Okay. There are times when enteral nutrition is not feasible, then you can use a parenteral nutrition. So if you have intraperitoneous fistula, mechanical bowel obstruction, radiation enteritis, and for those patients who have a high nutrition risk, Nutrix score of more than 5, or severely malnourished, okay, you can use parenteral nutrition as a supplemental as well. And you have to maximize parenteral nutrition efficacy initially with a hypercaloric dosing with adequate protein. And there's no difference in clinical outcomes for compounded PN versus commercially available PN. So you have to, as what I said earlier, you have to control your glucose to the desirable rate of 140 to 180. Okay, refeeding syndrome is a clinical complication that occurs as a result of fluid and electrolyte shifts during aggressive nutritional rehabilitation of malnourished patients. So it is marked by hypophosphatemia, hypokalemia, congestive heart failure, rhabdomyolysis, seizures, and fetal arrhythmias. It can occur both in enteral and parenteral nutrition, and the risk is directly related to the amount of weight loss during the current episode. and the risk is high in the first 1 to 2 weeks of nutritional replenishment and weight gain. So basically, management will include fluid and electrolyte replenishment. Okay, you have to monitor, you have to check your inorganic phosphate when this patient presents to you. Okay, you have to give thiamine, and you have to start the patient on a lower calorie count. Okay, maybe around 25% based on the current guidelines, 25% of the total caloric requirement initially. Okay, and then slowly increase it in the next few days. Okay, in order to prevent the food intake. Okay, I think that will be my last slide. Sorry, I think I overshot my time. Okay, for any questions, we can maybe accommodate one or two.
Thank you very much, Dr. Gumarao. I think we had a few people raising their hands earlier. Now is the time to ask your questions. Si Miss Margarita Cobambo, I'll allow her to talk now. I think the poll is already here now. Maybe you can answer the multiple choice questions first. Then it will be discussed by Dr. Gumarao. Then we can proceed with the chat box questions. So please, for everyone, please try answering the multiple choice questions. No? Maybe we can spend 5 minutes doing the multiple choice questions, and then Dr. Gumarao in the meantime can answer some of the questions of the attendees raising their hands. So, try this one. Okay, Dr. Margarita, you're allowed to talk if you have any questions. Other questions. So we have one question in the chat box, Dr. Gumarao. What's the best dressing for burn patients?
All right, yeah. So I think it depends on the clinician what you use, but usually in the textbooks you just have to you can use and silver sulfadizine dressing, right? It's the still recommended. Okay, but of course there are new burn um, dressings available in this. I think it depends on the clinician or your plastic consultant. I think what to use for your burn patients. Basically, in our institution, our plastics consultant also have our way how to dress your burn wounds.
Okay, thank you for that. So I think as general surgeons, we usually use silver sulfadiazine, but in reality, a lot of these patients will be different from their patients. So do we have other questions? Please don't be shy, and please start answering our multiple choice questions. 15 people allowed this class. Give a total of 5 minutes for our multiple choice questions. We have roughly 2 more minutes to go, and then Dr. Gumara will discuss the answers. Dr. Gumarao, I have a minor question now.
Yes, sir.
For a lot of people are curious on how you do PPL. Do you still do PPL in your institution?
Yeah, in our institution, we don't have the capability to do DPL. So that's why, yeah, I think there are only two hospitals previously that I know that uses DPL. One, of course, PGH, and I think the other one is Superior.
Mostly probably the big government hospitals.
Yes, yes. So personally, during my residency training, I wasn't able to do a DPL, okay, because our laboratory cannot do the analysis, because you have to have a good laboratory, and there should be expertise on how to read the aspirate when you send it to the laboratory.
Very much, Doc. I think, no, our time is up. It's been 5 minutes. Doc, Dr. Gumarang, would you like to start answering or discussing our next?
Okay, all right, thank you, sir. So, okay, let's, okay, number one. Okay. So I think a lot of, more than 100 residents answered. Okay, so for number one, there's a 25-year-old male rushed the ER due to a vehicular crash. Pupils were sluggish, eyes are open to pain, and he doesn't follow commands but moans periodically. So right hand does not respond to pain, but the left hand reaches for it. Both legs are stiffly extended. So what is his GCS score? So like what I said, you have to score this based on the best response of the patient. So so the eye opening is open to pain, which is around 2. Okay. For the voice, most periodically, it's around 2 as well. Yung motor response niya kasi is localizes to pain. So that's around, it's 5, right? So 5 to 2. So the answer is 9. Okay? So hindi siya 6. I think the others who answered 6, because they noted that the legs were stiffly extended. So akala nila decerebrate yung position. So not really. So yung motor response niya, okay, localizes to pain. So the answer is 9. Number 2, which one of the following statements concerning massive pneumothorax is true? So yeah, like answer is letter D. Okay, initial draining of more than 1 liter. So this is one of the indications for doing a thoracotomy after your chest tube. Okay, the other choices are not correct. Okay, so for number 3, okay, establishing a diagnosis of shock must include confirming hypoxemia. Letter B, confirming vascular resistance, documenting hypotension and low cardiac output, evidence of inadequate perfusion. Okay, so yung letter D is evidence of inadequate perfusion of the tissues there. So yung correct definition kasi ng shock, there should be an imbalance, okay? And then there should be evidence of end organ or tissue hypoperfusion, okay? So there are patients that are maybe have normal, okay, seemingly normal blood pressure, but if you examine them closely, they have end organ hypoperfusion already. So in order to establish a diagnosis of shock, very important yung tissue hypoperfusion. So letter D yung answer. Okay, for the trauma patient with cerebral edema, hypercarbia should be avoided to prevent acidosis, respiratory acidosis, C, vasodilation, D, neurogenic pulmonary edema. So most of you answered correctly. Okay, cerebral vasodilation. So CO2 in your blood will cause vasodilation, and you don't want that in your brain. Okay, so if there's more vasodilation, of course, then you aggravate your cerebral edema. So that's why you have one of your measures is to do if the patient is mechanically ventilated, then you want this patient to hyperventilate in order to blow off that extra CO2 from the blood. Okay, so that you can induce a vasoconstriction in the brain. So, but of course, up to a certain level only. Okay. Okay, number 5, 23-year-old stab wound patient, right upper chest above the nipples. He was intubated and CTT done. 1 liter of LRS and a pint of blood was infused. And BP is now 60/40. Okay, what is the next step? Okay, so most of you answered it correctly. Okay, so this is one of the indications as well for the for thoracotomy. Like what I said, after insertion of CTT, if you have a high index of suspicion of a thoracic injury and the patient is not improving in spite of a CTT, then most probably this patient will need an exploration. Okay, you don't need to do a CT because the patient is unstable. And of course, an angiography will not be helpful. Okay, principle of balanced resuscitation. Most of you answered it correctly. Good. Okay, there should be permissive hypotension and early plasma infusion. Okay. Number 7. Which one of the following findings should prompt immediate management during the primary survey? Okay, so if you look at that question, I was looking for sa primary survey. So if you review your ABCs, okay, una muna A, di ba? Sunod B, then yung C. Okay? So basically among the choices, wala siyang A. Right? Pero yung letter D mo is B. Okay? And then an RR of 32 is of course it's subnormal. So this is the part of your primary survey that you should be able to promptly manage during this time. Okay? So you don't manage the abdomen, don't manage the GCS, then of course pulse rate letter C siya, di ba? Then maybe madami namang ibig sabihin ng pulse rate na 120, baka in pain siya. Okay? So should be B, the breathing. Okay, so letter D yung answer. Okay. So I think that's all for this. Thank you everyone.
Dr. Tumaraw, it's nice to know that most of the participants answered the correct question. But before we let you go, maybe we have time for one more question. So there's just one question in the chat box. In level 2 penetrating neck injury, once the platysma is violated, upon gross inspection, is it mandatory to do neck exploration, even if with no hard and soft signs? Very common question.
Yeah. Okay, thank you. So if you look at the algorithm earlier, so if there are no hard or soft signs, okay, patient is stable, no abnormality in the hemodynamics, then you can do a serial examination, and of course you can do your imaging studies. Okay, as long as there are no hard or soft signs, it's not mandatory to explore.
Okay, thank you very much, Dr. Tumaraw. Thank you. So that concludes our first lecture for this morning. So Billy, can you just share the slides of our next lecture?
Thank you, everyone.
Oh, okay, so our second and last lecture for this morning will be regarding colorectal and renal surgery by Dr. Mark Fontanilla. Dr. Fontanilla took his general surgery training at the East Avenue Medical Center and his colorectal fellowship at Jose Reyes Memorial Medical Center. He had further training in colorectal surgery at the King Longhorn Medical Center and is presently the training officer of the East Avenue Medical Center Colorectal Center.